Good day, everyone. This is Senior Clerk Cubelo and another episode of Med Talks with Murray. And for today's episode, I will be demonstrating how to perform a tracheostomy procedure. Tracheostomy refers to the creation of a communication between the trachea and the overlying skin. This may be done either by open or percutaneous technique. To compare tracheostomy from tracheotomy, tracheostomy is a formation of a permanent opening that remains open after the tube has been removed. Compared to tracheotomy, this is the formation of an opening that will spontaneously close when the tracheotomy tube has been decannulated. For the indications, tracheostomy is done for airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, and for the treatment of obstructive sleep apnea. For the materials, we'll be needing a local anesthetic, suture set, tracheostomy tube, surgical set, electrocautery, and retractors. We place the patient in a supine position with neck extended by a pillow placed under the shoulders to deliver the trachea out of the thorax and to give adequate access to the cervical trachea. Palpate and identify surface landmarks. We have the thyroid and cricoid cartilage. Run your finger up the midline of the neck starting inferiorly at the sternal notch, and the first prominence encountered is the thyroid isthmus followed by the cricoid. Mark a line for the incision 1 finger breadth below the cricoid or 2 finger breadths from the sternal notch. The tracheostomy is created below the first tracheal ring to avoid subglottic stenosis as a result of scarring. For the skin incision, prepare the skin by sterilizing the skin of the anterior neck and the chest using cotton soaked in povidone iodine. Drape the patient properly in all 4 sides. Infiltrate local anesthesia and check after 2 minutes if it has taken effect before making the incision. Make a horizontal incision, which is cosmetically preferable to a vertical midline incision along the marked areas through the dermis. Excise the subcutaneous tissue using electrocautery. Intermittently palpating for the airway at this point is important as it is easier to stray from the midline. Dissect towards the trachea by parting tissues with scissors, remaining strictly in the midline in the vertical plane to avoid injury to the inferior thyroid veins. Once the fascia has been cleared away, identify the strap muscles, divide them at the midline, and retract them laterally. In cases where the thyroid isthmus is encountered, retract it superiorly to have a better view of the trachea. Ensure that the surgical field is completely dry before proceeding, as it is difficult to achieve hemostasis once tracheostomy tube has been inserted. Aspirating air with a needle attached to a syringe will confirm the location of the trachea. In the awake patient, inject lidocaine into the tracheal lumen prior to incising the trachea and inserting the tube to reduce coughing. Create the tracheostomy opening between the second and third tracheal rings. The safest tracheostomy in adults is to create an inferiorly based flap raised from the anterior wall of the third and fourth tracheal rings. A silk traction suture is passed through this anterior tracheal flap and loosely secured to the skin. Inject air into the inflatable cuff of the tracheostomy tube to test the integrity of the cuff. Tracheostomy under direct vision while applying traction to the silk traction suture attached to the tracheal flap. Ensure that the tube has been inserted into the tracheal lumen and not into a false passage in the paratracheal soft tissues. Remove the obturator, attach the inner cannula, inflate the cuff, and attach anesthetic tubing. Hand ventilate while correct placement of the tube within the trachea is confirmed by checking the expired carbon dioxide, checking for chest movement, or listening for breath sounds. Secure tracheostomy tube and do not suture the skin tightly around the tracheostomy tube, as this can promote surgical emphysema. That's all for today's episode. Hope you learned a lot and see you at the next surgical video. Bye!